Good afternoon all. I welcome all the participants for today's National Distance Learning Seminar Series. Today's topic is Response to ART, Virological and Immunological Discordance, and today's speaker is Dr. G. Manoharan. He is working as a medical superintendent at Karpagam Medical College Hospital, Professor of Medicine in KFMSR and Clinical Associate Professor in Department of Global Health, University of Washington and consultant with iTech India. He provides a technical assistance on clinical program management, training, curriculum development on HIV/AIDS. He holds the post of Clinical Associate Professor since 2009 at the Department of Global Health at University of Washington, Seattle. He is one of the TRG members at NACO and a national trainer for NACO. Thank you, sir. Thank you for accepting the today's NDLS session. Now I'm handing over the mic to Dr. Manoharan. Thank you.
Good afternoon all. I hope all of you can hear me well. It's nice to see you all after a long gap of almost an year. And today I am going to talk about a topic related to response to antiretroviral therapy, a challenging issue that is the virological and immunological discordance. So in this session, I am going to highlight on what is virological and immunological discordance, what is the importance and what are the causes of discordance, and what are the management approaches. In this session, mainly I am going to concentrate on patients who respond virologically, but they do not respond immunologically appropriately. I will discuss this particular issue only among adults. Children I am not going to include in this discussion. So, after initiating antiretroviral drugs to a HIV patient, what happens to the CD4 count? That's what this particular slide illustrates. So, in the first, there are three phases of CD4 increase once we initiate antiretroviral therapy. The first phase lasts for about 6 months, that is initial first month to 6 months, where the CD4 increases by 20 to 30 per month. And there is one author who says that this can go up to 10 months time. And then the second phase, where you get an increase of 5 to 10 cells every month, and this period lasts up to 2 years. And then the CD4 counts goes, and this can go up to 4 years, and some papers say it can go up to 7 years. So this is what we expect normally in a HIV positive patient who is started on antiretroviral therapy. Okay, so because of the HIV infection, there is a decrease in the CD4 count. And all of you know there are two types of CD4 cells. One is not two, that is naive CD4 cell and a memory CD4 cell. So immediately after the initiation of antiretroviral drugs, the memory cells which are stored in the lymphoid tissue is transferred back to the blood. So this redistribution of memory CD4 cells from lymphoid tissue towards the blood is responsible for immediate rise in CD4 count. So that is why in this initial period of 6 months, because of this memory CD4 cells, we get lot of IRIS related challenges also. So during the second phase and third phase, majority of the CD4 cells are produced from the thymus gland. So this is one mechanism by which the CD4 count increases. And the second mechanism is the CD4 cells, they divide the homeostatic proliferation of the residual CD4 T cells, which are responsible for the increase in the CD4 count. And the third mechanism is the extension of CD4 T cell half-life, a mechanism which is responsible for sustaining the number of naive CD4 cells in older individuals in whom the thymic production is impaired. So this is very basic, and this is a very important slide to know what happens when the ART is started to a HIV positive patient. Then let us see what are the responses we get in response to antiretroviral drugs. So in majority of patients, all of you know that the moment you start antiretroviral drugs, there is decrease in viral load to undetectable level, and also there is an increase in CD4 count as we described using the previous slide. And the next response is the viral load may decrease to undetectable level, but there may not be any rise in CD4 count, or if at all there is a rise, there is only a minimal rise in CD4 count. So these people are called virological responders. And the third response is there is minimal decrease in viral load, but there is a very good improvement in the CD4 count. So this group is called immunological responders. And there is a fourth group where there is neither a viral load response nor a immunological response. It is called non-response or non-responders. So these are all the four types of response we get when we start initiate antiretroviral therapy to a HIV positive patient. So in this session I am going to concentrate only on virological responders, the two in adults. It is only because of the time constraint I want to confine myself to virological responders, or you can call as immunological non-responders also. So let us go to a case study. Actually we saw this case at Government Hospital of Thoracic Medicine at Chennai, and though we come across 7 cases, similar cases, I am going to tell about one particular case, and this case study was published in Medical Microbiology in India. So it's a 49-year-old male, a South Indian farmer. He came with a report of HIV 1 and 2 positive in November 2006, and he was taking Siddha medications and cotrimoxazole. In February 2008, he was started on antiretroviral drugs, AZT, 3-TC and nevirapine, with a baseline CD4 count of 0. Previous CD4 counts were unavailable with the patient. So in May 2009, he came with an ulcerated lesion in the lower lip with a smooth margin and ulcerated base with a serous exudate. And AAB was negative, bacterial culture showed no growth, but the histopathological examination shows granulomatous tissue with predominant lymphocytes and epithelioid cells. And he was started on CAT1 anti-TB drugs. And other investigations, it's not very informative. The peripheral smear showed macrocytic hypochromic RBCs, WBC is normal, platelets adequate, no parasites. But the HIV test was repeated for HIV 1 and 2, and he was diagnosed to be HIV 1 positive, but the HIV 2 came as negative, and his viral load was less than 50 copies per ml, and during this period the culture from the lesion grown Staphylococcus aureus, and it was treated appropriately. So in March 2007 the patient improved well. The ulcer on the right side of the lower lip became non-tender with irregular margin and an indurated base with a little amount of crusting, and the patient improved slowly and steadily, and now he is without the ulcer and is still on antiretroviral therapy. So you look at his CD4 count, it was consistently 0 from 2008 to March 2011, and his viral load is also around 50 copies, less than 50 copies per ml. So this is a classical case of virological immunological discordance, and though in this case the immunological profile or the CD4 count is 0 consistently, usually we get a lower level of improvement as far as the immunological profile is concerned in spite of virological suppression. So this is what is called immunological non-responder or a virological responder. So today we are going to talk about only this particular challenge after initiating ART. So what is immunological non-response or what is poor immunological response after initiating ART? There is no consensus on this definition. If you look at the literature, many people tell many definitions for this, and if you look at the journal articles, each author have used their own definitions and their own criteria for this. So, in some articles they say CD4 count remained below a threshold, that is 350 to 500 cells after a variable period of time of ART, say 4 to 7 years. So, this criteria was used in some journals, and some others they have used the pre-ART CD4 cell count with the CD4 T cell slope during antiretroviral therapy. A possible definition for non or poor response could be a rise in CD4 cell count lower than 100 cells after 2 years of treatment, that is less than half of the expected recovery. And there are other definitions also. For example, there is a clinical surveillance study in which the patients are considered discordant if the CD4 was less than 200 before ART and failed to increase to more than 200 at least once and were grouped by the time the discordance at 0 to 6 months, 7 to 12 months, etc. with a persistent viral load of less than 50. Other study definitions of significant immunological responses to ART, some authors have said increase of 50 CD4 cell count per cubic millimeter or 100 cells per cubic millimeter, and some authors have used even 25 cells per cubic millimeter in 6 months period after ART. So all these definitions were used in the literature. That is why when you look at the literature, the incidence and prevalence of this particular condition is also varies. So some say the frequency is 6 to 24%, and another journal says it is around 9 to 29%. But anyhow, it's around 10% or 15%. And even in our program, when we sit in the state AIDS clinical expert panel, we come across around 10 to 12% of virological immunological discordance in our program. So that is the importance of this particular topic. Let us see why this topic is very important. Because if you look at the literature, almost all the articles say this poor immunological response, immunological non-responder, the long-term clinical outcome is very, very poor. So let us see what is the evidence for this. So if you look at this particular journal, in this particular slide I have shown you the name of the journal, and if you look at this graph, so in this the non-AIDS or AIDS related morbidities, mortalities, AIDS related events are quoted in this axis, and the response to CD4 cell after ART, less than 25 cells and more than 25 cells are also quoted in this Kaplan-Meier curve. So if you see, if it is less than 25 cells increase after 6 months, the mortality and the non or AIDS related events are quite high in this particular group. And also the response is defined by absolute CD4 count. This is more than 200 increase, and this shows less than 200 increase. So after 6 months period, if the CD4 is less than 200, then the AIDS related events are very high compared to patients who have shown good improvement in CD4 count. So this article clearly says patients with virological suppression are still at risk for HIV disease progression if adequate immunological responses are not achieved. A similar study, it's called ART cohort collaboration study, also found that all CD4 cell count levels less than or more than 25 cells per ml were associated with reduced risk of all-cause mortality when compared with cell counts of less than 25 cells. So let us see more studies. So if you look at this particular study, the patients were categorized into 4 groups. So in the first group, it's a concordant response, that is both virological response and immunological response, positive response. And here it shows immunologically they are better, but virologically there is no response. And this is the group which we are discussing now. There is virological response, but there is no immunological response. So you compare this particular group and this particular group as far as the death and opportunistic infection and death are concerned. So in this particular group, it is considerably high. And the incidence rate is 8.7% at a virological response only among these 404 ARV naive patients who were started on antiretroviral therapy. And if you look at the Kaplan-Meier curve, then you see the immunological non-responders, they don't fare well like immunological and virological response people. The time to death or development of an opportunistic infection based on immunologic and virologic response in 3 months after initiating antiretroviral therapy. Okay, coming to another study published in AIDS 2012, again the study says despite virological successful heart, it is associated high risk for overall mortality and morbidity and cardiovascular events if the CD4 count is not improving well. That is poor immunological recovery despite virological response leads to overall morbidity and cardiovascular events. Let us see some of the responses from this study. So in this study, the initial CD4 count is given and the patients are grouped into group A, B, C and D based on the CD4 count at the time of initiation, that is less than 200, 200 to 350, 350 to 500 and more than 500. So in this study also, you see in group A, the composite endpoint, that is all-cause mortality, the cardiovascular events, all malignancies, cirrhosis liver, AIDS, death, everything is included in this A slide. In the B, it is a non-AIDS defining diseases are included. In slide C, the cardiovascular events are included. And in D, non-AIDS defining malignancies are included. In all these 4 sections, you see the immunological non-responder fared comparatively poor when compared to the immunological and virological responders. In all the 4 groups, this particular group fared not well when compared to virological and immunological responder. So this study clearly says that antiretroviral naive patients on ART with poor immunological recovery despite virologically successful, they are at higher risk for morbidity, mortality and cardiovascular events. So all these studies clearly says that poor immunological response is responsible for higher mortality and higher AIDS related events, non-AIDS related events and cardiovascular mortality. And another study on immunological non-responders says higher risk of severe clinical events than responders. So here you see, in this study, the total number of patients if you see the number of patients and the number of events as per the patient years follow-up is given here. If the response is good, here then there is no INR, that is immunological non-responder, the events are only 1.84, and if the immunological non-responder is, the event rate is 4.41, and they are stratified according to the CD4 count. If you see, if it is less than 200, whatever the CD4 stratification, you see the number of events are high in the non-responder. So this study clearly states that immunological non-responders are prone for many complications, not only AIDS related but also non-AIDS related complications. Again, the same points are described in the Kaplan-Meier curve, and this is the response. So compared with complete responders, virologically respond group had a hazard ratio of 1.9 with a confidence interval of 1.3 to 2.63. So why this immunological non-response is important? Because poor immunological response, despite appropriate viral response, caused increased mortality and morbidity, increased non-AIDS events, especially cardiovascular events, AIDS-related malignancies, and AIDS-related events. So, so far we have seen what is virological immunological discordance and what is its importance, and now let us see why this discordance happens. What are the reasons for this immunological virological discordance? There are a number of reasons quoted in literature. I first tell you what are the possible causes. One is the bone marrow suppression by the use of azithromycin, that is AZT, use of systemic corticosteroids and chemotherapeutic agents, use of cotrimoxazole. IV drug use is associated with the poor immunological response, and some ART regimens. It is common with NRTA only regimens compared with PI or NNRTA containing regimens. The other reasons are reduced thymic function, increased immune activation lead to lymphoid tissue fibrosis, co-infections other than tuberculosis, which include hepatitis C co-infection, Sjogren's syndrome, and sarcoidosis. So there are so many reasons why this immunological non-response occurs. Let us see some evidence for all these causes. So this particular slide taken from a review article from a journal called Blood. There are many reasons for this, and I am going to highlight only on some important things. So let us see what happens to the bone marrow and thymus output. So earlier I showed you, when we start antiretroviral therapy, initially there is a 20 to up to 20 cells increment per month during the first 6 to 10 months. So the thymus produces lot of CD4 cells, and also the initial period, the shift of CD4 cells from the reservoir site to the blood. So what happens? The thymic output is less in these poor immunological responders. See, when we look at the naive CD4 cells, the importance of naive CD4 cell gain during the first 4 weeks of therapy, and there is a relationship between this and the abundance of thymic tissue. The another factor is the HIV infection per se impairs the hematopoietic stem cell metabolism and thymic function. And some of this impairment may be partially irreversible. That is why even if you start antiretroviral therapy, the thymic output of naive CD4 cells remains suboptimal in some patients, leading to poor immunological response. And another reason is related to this thymus output is polymorphisms in gene coding for the cytokines IL-2, IL-15 and also IL-15 receptors. They are also involved in the maturation and development of T cells, and this polymorphism is also associated with poor immunological response. And coming to HIV pathogenesis, there are a lot of literature on this particular topic, and the main point here is, see, when the virus infected a CD4 cell, it goes to the resting stage, and also when the virus multiplies, there is diversification of HIV sequences in aviremic patients, and this ongoing replication of HIV virus is responsible for the poor immunological response. One evidence for this is when we give what is called the intensification of antiretroviral therapy, it improves the CD4 count. Though this particular point is controversial, still this HIV sequence diversification and also the ongoing viral replication, subclinical replication is very important point in immunological non-response. And the third important point is immune activation. This immune activation, again due to residual HIV production, which I discussed earlier, and again age is also responsible for this. Older persons have a higher background of immune activation than younger ones. So this might contribute, in addition to their reduced thymic output, to the link between age and suboptimal CD4 progression. So from a general point of view, immunosenescence might be a cause and a consequence of immune activation, and it leads to poor immunological response, and it is a vicious cycle. And the third important point is what's called the co-infection. Hepatitis C co-infection and also cytomegalovirus infection and also Mycobacterium avium complex. These co-infections also cause immune activation, which is responsible for immunological non-response. And another important point is what is called microbial translocation. I think all of you know, immediately after the HIV infection, the HIV infection causes and decrease in CD4 count mainly from the gut associated lymphoid tissues. So this is, in short, it is called GALT, G-A-L-T. So because of this destruction and the microbial organisms that are present in the lumen of the intestine, they enter into the walls of the intestine and causes a lot of gastrointestinal manifestations. So what happened? This early infection causes depletion of CD4 cells in the GALT, that is gut-associated lymphoid tissue, and this is preserved and this is present. This destruction is not reversible fully. So this partially, the destruction is continuing, and this destruction is also responsible for poor immunological response. And there are many more issues like genetic factors, like apoptosis is a form of cell death responsible for CD cell loss during HIV infection. As you know, all the CD4 cells come together because of has been inversely correlated with CD4 T cell progression after HAR. Therefore, it is not surprising that polymorphisms in gene involved in apoptosis, such as there are many examples given, linked to the rise in CD4 cell count throughout the therapy. And the third one is gender. This is a very important point. Men have been reported to be at higher risk of non-CD4 cell response under heart than women. The explanations are thymic output is higher in females than in males. Another reason could be anti-apoptotic effect of female sex steroids on CD4 T cells, as observed, for instance, on neutrophils. So these are the two reasons why the immune responders are mainly males when compared to the females. And there are some genetic factors like genetic polymorphisms in the genes coding for CXCR4 binding chemokine, that is CXCL12, SDF1, for the chemokine receptor CX3CR1, and in genes located in major histocompatibility complex. So all these genetic factors are linked to poor CD4 response. Any questions so far? I don't see any questions. Okay. Now there are other reasons for poor CD4 cell response. All of you know that zidovudine is one of the main drugs which we use in the national program, and you see this particular article says zidovudine impairs immunological recovery on first line antiretroviral therapy. So you see this curve, those patients who are not on zidovudine, the CD4 response is statistically significant, that is very good CD4 response compared to patients who are on zidovudine based therapy. So zidovudine is associated with inferior immunological recovery compared to other backbones. And in the same study, they say male patients, those older than 40 years, and patients with very low CD4 counts at the initiation of ART, they are also at increased risk of impaired immunological recovery. You look at the data here, it clearly says the immunological recovery is not good in these groups. And there are still more studies talking about zidovudine and the poor immunological response. If you look at the literature, there are many studies which quote that zidovudine may cause poor immunological recovery. So why zidovudine causes poor immunological recovery? Because association of zidovudine with impairment of total CD4 lymphocyte recovery are poorly understood. The most probable explanation is related to the bone marrow suppression caused by zidovudine. You know that the CD4 cells are mainly produced from thymus and bone marrow, and in case of bone marrow suppression, definitely we expect low CD4 count. But the data from the Swiss HIV cohort study says it is a general effect on total lymphocyte count rather than a specific CD4 specific effect. So this is the reason why zidovudine causes poor immunological recovery. And there are some other reasons also. The concomitant use of diadenosine with tenofovir, but we no longer use diadenosine in our program, and genetic variability such as polymorphisms associated with drug transportation and T lymphocyte apoptosis, which we already seen. And another study again talks about the discordant responses, especially immunological non-response. They were older, they had higher baseline CD4 cell counts, lower baseline plasma viral load, likely to have received a non-standard heart regimen. So in this particular study, these are the reasons quoted for poor immunological response. So in this study, the total number of patients were 4,800, and around 364 patients had the poor or immunological non-response, and this particular study quoted the 4 reasons for the poor immunological response. Why old age is responsible for poor immunological response? Because the magnitude of immunological reconstitution is dependent on thymic activity, and the thymic activity decreases with age. Older age is independently associated with impaired immunologic reconstitution despite sustained virologic response. So coming to the management, in this particular slide, I have just mentioned few important points regarding management. Cotrimazole prophylaxis, because we are supposed to continue the cotrimazole prophylaxis as per our national program, depending upon the CD4 count. So in patients with a poor virological response, even if they are taking ART for 2 years and 3 years, if the CD4 count has not improved properly, we have to continue the cotrimazole prophylaxis, and we need to reinforce adherence to the antiretroviral therapy. And there are some papers which talk about intensification with raltegravir and Manoharan, but there are some recent articles talking about the usefulness of the intensification of the raltegravir and Manoharan. And other journals say the change of heart may improve the CD4 response. Again, there are articles against this particular point. And we can switch to PI based antiretroviral therapy, which may increase the immunological response. And there are few trials with the interleukin 2 and immunological response. But even in this particular condition, even though you give interleukin 2 and even though it increases, it does improve the immunological response, the all-cause mortality and morbidity is not improved with this particular thing. And there are many other therapeutic possibilities. One is, say, let me go back to a previous slide, which talks about this slide, which talks about the bone marrow, thymus output, HIV pathogenesis. Let us see, can we do something on these particular points. Coming to insufficient thymic activity, there are articles talking about the use of interleukin 7. So interleukin 7 is a good candidate because it promotes maturation of thymocytes, its survival, and the function of T cells, as well as the hemostatic expansion of all T cell subpopulations. And also IL, that is interleukin 15, has also been considered to boost the immune recovery. So we can use interleukin 15 and interleukin 7 to boost the CD4 recovery. And another option, when I discussed about the sex and the sex hormones, another option might be to inhibit the production of sex steroids, because as estrogens, progesterone and testosterone induce thymic atrophy, probably mainly through their effect on thymic stroma, castration has been tested with success to boost thymic activity in animals. Accordingly, in humans, the administration of LHRH, that is luteinizing hormone releasing hormone agonist, has resulted in transient enhancement of thymic function, particularly after hematopoietic stem cell transplantation. Obviously, although chemical castration is temporary, the gain in thymic output will have to be balanced with side effects. See, I am telling all these things are only published in literature as options to produce immune recovery. And another alternative way to sustain thymic activity is to induce thymic epithelial cell proliferation by using keratinocyte growth factor. So these are some of the ways by which we can improve the thymic activity and thymic output. and also the use of growth hormone. The growth hormone is supposed to enhance hematopoiesis and immune function both directly and via insulin-like growth factor 1. Growth hormone treatment has been shown to improve thymic function in HIV-1 infected people. But here again, we need to think about the adverse events like carpal tunnel syndrome, hyperglycemia, etc. So there is one question from Gulbarga. In case of immunological non-responder, how to assess treatment failure? Because some patients at our center were referred to viral load, which was reported as TND. Can you tell me what is TND? HIV-2 also ruled out. So as per our national program guideline, if the patient showed, that is, the viral load is suppressed, but the CD4 count response is very poor, even it comes to treatment failure range, then we are supposed to continue the same antiretroviral drugs, that is first line drugs, and you try to find out the reasons for poor immunological recovery, and probably this session may give you some idea how to improve the CD4 count. Otherwise, you have to continue the same antiretroviral therapy as per the national program, provided you have ruled out HIV-2 infection. I hope I answered your question. Okay. Another question, as you said, cotrimoxazole itself causes bone marrow suppression, but we have to continue CPT for poor immunological response. It's a good question. See, many of the patients, the CD4 count recovers more than 250. In those cases, we need not give cotrimoxazole. But in those patients where the immunological recovery is very poor, then we are supposed to continue cotrimoxazole, because you know the benefits of cotrimoxazole much high, because it prevents many opportunistic infections. But you try to find out whether this cotrimoxazole is responsible for the bone marrow suppression in that particular individual. If it is so, then we have to stop cotrimoxazole, give another drug to prevent opportunistic infections. But if a case where the CD4 count increases to more than 250 or 300, there is no need to put cotrimoxazole prophylaxis in those immunological non-responders. Hope I have answered your questions. What better ART options are available in patients who are having low CD4 count and plasma viral load was also below detectable levels? This is from BJMC Ahmedabad. See, I told you in the national program we need to follow the national guidelines. I told you some of the antiretroviral, for example, AZT may be responsible for poor immunological response. In those cases, as per the national program, if they develop bone marrow suppression, naturally their hemoglobin will low, and we can definitely go for tenofovir based NRTI regimens. And in the national program, we are not using diadenosine, we are not going to use NRTI triple drug therapy, etc. So those reasons may not come into picture at all. And the treatment intensification, I told you, is not a better option, because there are few papers who talk about not using this treatment intensification. I hope I answered the question for COE Ahmedabad. Any other question? Okay. Then coming to, so when I talk about the management principles, one is we can improve the thymic output, and I told you a few reasons of using IL-7, IL-15, reasons related to sex steroids and carotenocyte growth factor and also the growth hormone, including their side effects. And another reason is the ongoing viral replication. I repeatedly mentioned that the treatment intensification is not yet universalized and we cannot practice as on today. And the third important point is immune activation. Immune activation can be taken care of by many methods. One is you can, because in the past various attempts to downregulate the immune activation in HIV-1 infected patients were there. These attempts included use of hydroxyurea, thalidomide, mycophenolate, steroids, IL-10, etc., etc. So they have used various agents to downregulate the immune activation. But most of those attempts were disappointing. And if CCR5 is actually involved as a co-activation molecule into this immune activation, CCR5 antagonists could exert some inhibitory effect on it. So CCR5 antagonists could exert some inhibitory effect on this particular point. So in this case, hot intensification with Manoharan has resulted in decrease in proportion of activated peripheral blood CD4 and CD8 and increase in CD4 T cell slope. So in these cases definitely we can use Manoharan, but it's not available in the program. Okay. Then coming to the residual viral production, that another reason for immune activation. In this case, the way to stop HIV-induced immune activation will be to get rid of the reservoir cells that continue to release virions even though these virions do not cause de novo infection. This goal is presently pursued by some groups with different approaches, including brief induction of viral overexpression with the aim of inducing a cytopathic effect. For this purpose, they use cytokines IL-2 or IL-7, activation of protein kinase C, and agents remodeling the chromatin, intravenous immunoglobulin injection, and the latest one is microRNA manipulation. But these are all not practical methods, but the literature says all these modalities can be used. And another important point is related to this co-infection and immune activation. If active co-infections reinforce the global immune activation, the infectious agent's response for these co-infection might be targeted. So we can target these HCV co-infected adults, and in the same way we can use valganciclovir for CMV seropositive HIV infected patients when the CD4 count is lesser than 350, and also in Mycobacterium avium complex patients you can use the appropriate antibiotics. So these are all some reasons. These are all some reasons by which you can improve the CD4 count. And there is a question, what is the use of changing ART regimen for poor immunological response? So I told you there is no need to change antiretroviral therapy at all. In the national program, if the patients show good virological response, we need to continue the same antiretroviral therapy. I am repeatedly telling in this session, the only option is the treatment intensification, especially the reason behind is immune activation by CCR5 HIV viruses. So in those cases, Manoharan can be used, but we do not have that particular drug in our national program. This is just response the ART is plus center Salem question. Okay, so let us continue. There are only 2 or 3 slides. So far we have seen what is poor immunological response, why the poor immunological response is important, what are the reasons for this poor immunological response, and what are all the management principles, both experimental and practical. So the important key point on this particular session is complete virological suppression is the therapeutic goal, but CD4 response appears to be an important predictor of risk for disease progression. So HIV physicians need to ensure such immunological response in their day-to-day practice. So there is one more question. Apparently healthy client but peripheral viral load not detectable. CD4 count 7. Kindly elaborate. See, you saw the case study which I have given you at the beginning of this session. In that case the CD4 was 0. So it is related to the same case study, the immunological non-response. So you try some of these methods which are described in this particular session, but you continue the same antiretroviral drugs which you are giving to that patient because the viral load is undetectable. See whether the patient is on zidovudine based therapy. See whether the patient is HIV, the hepatitis C positive or cytomegalovirus antigen positive. So try to rule out all these reasons so that you can take care of the immunological non-response. This is for General Hospital Chandrapur's question. So this is my final slide, and if you have any questions, we can discuss, and we have still 5 minutes for question answers.
Thank you so much for your valuable session, sir. If any questions are unanswered, sir will.
I think I have answered almost all the questions. Okay, there is one question that CD4 count can be low in leukemias. Yes, again it is because of the bone marrow suppression and the thymic output is very, very low for Karnataka. Any other questions? Let me look into this chat box. Okay, there's a question. In case of immunological non-responders, how to assess treatment failure? Because some patients at our center were referred for viral load which was reported to be HIV2 ruled out. I think I answered this question also. Okay, I think I have answered almost all the questions. If there are, okay, that's another question. HIV-1 non-response on ART, 6-year-old girl with encephalopathy. I think we need to find out what is the cause of encephalopathy. Is it HIV encephalopathy or encephalopathy due to any opportunistic infections? I think if you give me more details, and we can discuss about this particular case. So in this case, we need to know whether viral response is there, is it undetectable or not, and other clinical picture, what are the other OIs. Probably you can send an email so that we can discuss and we can talk about it. And there's a question from Salem, what about third line antiretroviral therapy? You please wait for the NACO's announcement for the third line antiretroviral therapy.
Thank you so much for your valuable session, sir. I hope that participant enjoyed the session, and then most of the questions, I think most of all the questions are answered. Now I'm requesting all the participants to kindly enter the e-poll displayed on the screen.
So thank you everybody for your patience listening. Thank you very much.